Hello, everyone. I would like to thank Agilent Technologies for the opportunity to speak here today. So I'm going to tell you a story today about how a target custom panel has helped to become such a critical tool to the success of our research, and this has translated directly to patient care. I don't have any disclosures. So the objectives for today, I'm going to define clonal hematopoiesis. I'm going to outline the genetics of myeloid malignancies and describe a little bit of the clonal trajectory. And then I'm going to go into some of the clinical scenarios which has helped organize our vision and execution of a pre-myeloid clinic, which has been a journey and still is a journey of bench to bedside practice. And finally, I'm going to highlight some of our accomplishments as well as some examples in the field and what we've learned and kind of where we're headed. So the definition of clonal hematopoiesis is the acquisition of somatic acquired variants in hematopoietic stem and progenitor cells with the potential for subsequent clonal expansion over time. So our genome is inherently susceptible to mutations over time. The most common reasons are indels that occur because of defects in DNA replication as well as repair. There's endogenous toxins that we're continuously exposed to our whole lives, whether it's our skin and UV light, smoking in the bronchial epithelium, alcohol in our liver, or spontaneous chemical modifications due to deamination or transcriptional strand bias. Now, it's common for all cells in every organ and tissue type to acquire somatic mutations as we age, and more than 95% of these are passenger mutations, which we all know. But the other 5% have some significance for different organ systems. But today, I will just be focusing on the changes that appear in the blood. So clonal hematopoiesis is not a new kid on the block. First observations going back to 1996 when non-random X inactivation was first described in females. And this group very astutely observed that this had to be clonal in nature. But it was only in the 2000s when next-gen sequencing became available that people were able to deduce that these were actually somatic mutations. So on the right here, this is the same group publishing in 2012, showing that these non-random X chromosome inactivations were associated with TET2 clonal hematopoiesis, and that these had an effect and produced epigenetic changes. So TET2 activity can be measured by the levels of 5-HMC and 5-MC. Since then, there's been a number of large prevalence studies, and one of the largest of these is very well known. It was performed in 2014. This group looked at over 17,000 blood exomes in normal controls and patients with diabetes, and they found evidence of variants in genes relevant to hematologic malignancies. And what they found was this was clearly an age-related phenomenon, normal age-related phenomenon. So by the time you're 80 to 90 years old, you have a 10 to 20% chance of having CHIP, clonal hematopoiesis of indeterminate potential, or a mutation in a gene known to be relevant in a myeloid malignancy using conventional techniques. But of course, if you use deeper sequencing, this prevalence increases. And what was surprising was the type of genes that were mutated in these patients. So over a third of these changes were only cited in 3 genes. And all of these genes are very important in epigenetic regulation. DNMT3A is a critical regulator of methylation. TET2 we know is an epigenetic eraser as well as writer. And ASXL1, which is very important for chromatin regulation. But it wasn't just these genes. There were other genes where we hadn't previously known that they would be present in intact hematopoiesis, and so this was very surprising. Most of these changes were C to T transitions, which is a signature in an aging, and this is an aging population. However, some patients actually had 2 mutations, and these were typically seen in DNMT3A and TET2. And the only phenotypic correlate that this group of patients had in their blood was they had a slightly higher red cell distribution width, and their differential was slightly skewed toward monocytosis. That was it. And not surprisingly, the outcomes, they had an increased risk of hematologic malignancies. The hazard ratio was 11. But also, they had an increased all-cause mortality and risk for cardiovascular and cerebrovascular events too, which was very thought-provoking and surprising. So we know a lot about the genomics behind myeloid malignancies and myeloid neoplasms. As we stand here today, more than 95% of these cancers, patients that have MPNs have one or more mutations in several specific gene groups. These include the epigenetic regulators, TET2, DNMT3A, IDH1 and 2, splicing and spliceosome components, transcription factors, tumor suppressors, cell signaling, kinases, and also the genes that are important for cohesinopathies. And there's been elaborate single-cell studies and next-gen studies which have shown that there's a mutational hierarchy in the progression of this disease, where patients, the first initiating events are mutations in epigenetic regulators and spliceosome components. These patients present with cytopenias and dysplasia. There seems to be a period of latency, and then they acquire other abnormalities involving transcription, tumor suppressor genes like p53, and of course the kinases, which give the cells a proliferative advantage and potentially or eventually into the most feared complication, which is acute myeloid leukemia. And as you can see on the bottom here, these variant or the subgroups of these myeloid neoplasms have a lot of clinical overlap, but there is two polar ends. One is dysplasia, cytopenias, and the other is extreme proliferation. So the Papa-Manuel group from the UK-based Sanger sequencing domain have published extensively on myeloid neoplasms, and I'm showing a paper from 2013, but this is a landmark paper. And the mutations which have been described here have been consistently validated in other studies across the world. And you can see a plethora of mutations that have been described, but what I want to highlight here is on the right, on the upper side. So this is an MDS. The more driver mutations you have, the worse your outlook. So the red line here at the top indicates patients with more than 6 mutations, and these patients with MDS survived less than a year, and we know this. But on the bottom is very interesting, and it rings true today as well. So these are VUSs, and they were predicted by in silico algorithms to be either indeterminate or not predicted to be damaging, and you can see even these patients with VUSs did poorly. So we, as we matured into designing what we wanted to do in our research, we realized there's much more to the story than just looking at a genetics report and saying, yes, you have a pathogenic mutation, or no, these VUSs are inconsequential. So there's a lot more thought that has to be placed on functional relevance in these variants. So this slide shows the progression from somatic mosaicism through clonal hematopoiesis and into a hematologic malignancy. And what I want to highlight here is once you acquire a mutation that is involved in clonal hematopoiesis like DNMT3A, ASXL1, TET2, we know you can live the rest of your life. These clones can just circulate the rest of your life and you will be fine. However, if there's a particular influence on this clone, a selection pressure that expands this clone, the patient now, these clones evolve, and now they become, the patients have dysplastic cytopenias, and they are characterized in a pre-leukemic state. So there's clonal cytopenias of undetermined significance, aplastic anemia, MDS, and then they transform into an overt heme malignancy and AML. So the basket or the place where they're at in the pre-leukemic state still needs to be further stratified, and there's a whole bunch of patients that are in this realm right here. So a lot of cases that are referred to the Mayo Clinic just have low blood counts. And it's not uncommon for a pathologist to look at the bone marrow and say, you know what, there's not enough evidence to call a myeloid malignancy or some other heme malignancy at this point. And a lot of times these patients are sent back for monitoring or sent back to their primary care physician. And there's some patients who have subtle dysplasias or mutations identified without a diagnostic abnormality in the bone marrow. And so it's tough to place these cases. Right now we have operational definitions where we can kind of put them. where in the middle here, CHIP, clonal hematopoiesis of indeterminate potential. This is fast being recognized as a very important condition. It can affect multiple organ systems, and this involves a mutation, a leukemia-associated driver gene with greater than 2% VAF, without an underlying heme malignancy or abnormal blood counts. So most true CHIP patients have normal CBCs, and you'll only pick them up through deep sequencing panels. When this condition is now associated with persistent cytopenias or with no overt evidence of MDS, usually the VAF is increasing to greater than 10%. We refer to them as a clonal cytopenia of undetermined significance, and this is a precursor condition to myeloid and lymphoid neoplasms. So this right here forms a large group of patients that need support in prognostication, stratification, assessing, predicting how often they should be followed, what is their risk of evolution down the line. So we're so siloed into cancer-specific syndromes that we have patients that, they're not heme malignancy patients, so they get shuttled to rheumatology or they get shuttled somewhere else and different departments. And so we don't know what's happening with these patients. They're falling through the cracks. And so we built a clinic, a pre-myeloid and bone marrow failure precision medicine clinic, one of the first of its kind, led by Dr. Mrinal Patnaik, who is a patient advocate. He's very intense. He's been an integral and intimate part of every aspect of this clinic and has driven it, his heart. It's a unique heme service line clinic to prospectively screen and follow high-risk individuals with somatic mutations in their blood compartment. So our goals are to prospectively identify clonal cytopenias and further stratify these, CHIP, CCUS, or low-risk MDS. And number two, to focus on variants of undetermined significance, build our clonomics core to help with these downstream functional validations, like in silico analysis, RNA sequencing, chromatin immunoprecipitation, methylation studies, and if needed, isogenic cell lines. So this is a novel clinic. We have actually unmasked a multidisciplinary team, pipeline consisting of unique collaboration between clinicians, molecular biologists, bioinformaticians, genetics, and this represents a true bench-to-bedside approach. And I want to underscore this by saying that if you're a patient and you have low blood counts and you're not diagnosed with a heme malignancy, then you want to order a clinical panel to see whether or not you have a relevant mutation in your blood. Sometimes the insurance companies will not reimburse you. And these testings panels are very expensive, sometimes in the thousands of dollars. So the NIH is prospectively collecting data from and other multiple large centers, and we are collaborating in order to provide enough data to justify to these third-party payers and insurance sources that in certain cases, this is something that's integral to the best outcomes for these patients. And so that is another reason that we started this clinic. But until then, there's a big struggle. So we are providing a home for these patients where we can prospectively identify them and provide them with a multidisciplinary approach that they deserve. So these are some of our referral indications. Number one, we get referrals from incidentally discovered somatic mutations in the blood compartment in whole or targeted exome genome sequencing studies. An example of this is an IDH1 mutation discovered in a patient screened for lung cancer through Foundation 1 testing, or a TP53 mutation that was found in a cohort of patients screened for Parkinson's disease. Number two, screening for patients with unexplained cytopenias. So an example is a patient with a prolonged unexplained cytopenia greater than 3 months without an evident cause or dysplasia on bone marrow, undergoes NGS testing, and was found to have a DNMT3 mutation. Third is clonal hematopoiesis suspected due to mosaic results from germline testing. We get a lot of these for cancer and hereditary syndromes. 4, young patients less than 50 years of age, patients prior to chemotherapy, such as breast or ovarian cancer, follicular, non-Hodgkin's lymphoma, or other cancers prior to adjuvant cytotoxic chemotherapy or intensive radiation therapy. And number 5, Screening prior to autologous hematopoietic stem cell transplant. So these typically include amyloidosis, non-Hodgkin's lymphoma, and myeloma. And what's important is that all of these patients have unique phenotypic characterizations. So a lot of patients we see only present with autoimmune a phenotype or arthritis, or the physician happens to notice that they have a low blood count and they're like, oh, maybe we should refer them to hematology. And this is how we catch these patients. And so it's very important to know that there's lots of other things going on and the patient may not be captured by just a blood abnormality. So this is an example of our pipeline. So the patient is referred to us. They're evaluated by a hematologist, genetics counselor, nurse, and our CRC team. We do NGS testing on every case that comes through with a custom target capture deep sequencing panel. If the patient's positive for genetic variants, we have a tumor board consulting twice a month where we go over the patient's clinical information and we follow up using exome sequencing, omics, or functional tests. If there's a diagnosis for the patient, then we can provide evidence-based multidisciplinary management recommendations. And if not, we can go back to their original case and go over it again to see what else we can find out. And doing this for the last several years has led to we're very proud, this has led to us to be able to stratify this pre-myeloid clinic into 3 distinct clinics now. One is the Clonal Hematopoiesis Cytopenias clinic. We have a very robust telomere biology disorders clinic where we've been able to merge with patient foundations, and this has been very robust collaboration. And also familial predisposition and inherited bone marrow failure clinics. So for the Clonal Hematopoiesis clinic, we get referrals from genetic panels for lots of different causes. The outcomes for these patients is not necessarily neoplasia, but some of them progress. A lot of these cases have monocyte dysfunction, inflammation of the endothelium, cardiac plaque destabilization, and so we have solicited pulmonologists, cardiologists, people that we know are perfect for these types of phenotypes that the patients can go to for care. And what this clinic does is evaluate the patients who meet criteria for a cytopenia of uncertain significance and see if we can simplify our approach to stratifying them. So some of the questions we ask are their marrows hypercellular and they have an unexplained cytopenia and they don't fit into MDS, but if they have a clone, what type of mutations do they carry? And can we stratify these? If they have a VUS, can we functionally characterize them? Can we prognosticate and see how these are going to evolve? If the marrows are hypocellular, are they marrow failure states? Could these be an underlying undiagnosed germline syndrome? And we've seen a lot of these come through. Are there mutational hierarchies in these marrow failures, and can we stratify these? Overall, this helps us link that this is a clonal process. We're very intrigued by VUSs that seem to come in and trend with these cases too. Normally you see these on the 3rd page of the clinical report when you go to your physician and well, there's nothing we can do, there's no pathogenic mutations, so there's nothing we can do on this. So we're here to help with this functional validation and assemble the teams and the pipelines and the infrastructure to be able to do this by using in silico analysis, like I told you before, RNA sequencing, CHIP, methylation studies, and cell lines. So this is an excellent review performed by some of my colleagues at the clinic, showing that the prevalence of CHIP really depends on the sequencing technique that you use. Everybody here knows this. So if you use deeper sequencing with target capture assays or error-corrected sequencing with indexing, you can find that even individuals in their 2nd and 3rd decade of life have a prevalence of CHIP. And this leads me to the heart of our clinic, our target capture panel. We started this panel before the clinic, and it has become our reliable, robust tool that we use to build this clinic around. In terms of clinical application, targeted NGS-based assays are preferred over whole exome sequencing or whole genome sequencing because of the cost effectiveness, sufficient read depth, while maintaining a manageable throughput of data. So we wanted to include all the genes relevant for cancer development and hereditary syndromes on this panel. Our custom capture panel includes 220 genes. We chose Agilent SureSelect Custom because we found, we liked working with Agilent. We found the ability to interface with custom design to be super easy. Our genome core facility at Mayo Clinic has significant experience with Agilent chemistry and recommended the XTHS library prep and target enrichment over other companies. And finally, our ability to access and analyze raw data using their platform and be able to incorporate molecular barcode tags to aligned BAM reads in, using single consensus reads. And what I want to do is highlight, so this is a picture I took the other day. This is our Mayo Genome Core facility. And I just want to highlight this person, Kit Lee. So he is behind the scenes. He's never been recognized before, but he is one of the essential reasons that we're so successful with our research because, you know, he works above and beyond his station. And I wanted to highlight him today because he is our genome core. And he's standing next to his very favorite instrument, which is the Agilent Bravo automated liquid handler, which is the other half of the genome core. And I don't know which one works harder. So here's a list of the relevant genes that we included on our panel. We wanted to include leukemia-relevant genes, germline predisposition genes, and also any known driver genes in other cancers. So this is our flow process. It's still fluid, lots of moving parts. It's refreshing to hear a lot of presentations here with the advancement that we've made in variant curation and other parts of these, variant evaluation criteria. We have a tumor board where we review all of this, and it's very fluid. And I have to say that a lot of our findings are research-based right now because CLIA certified testing, takes time to incorporate, and so we do a lot of this on the research side. So a lot of our findings are still currently having to be validated by CLIA certified labs before they're actionable. And thankfully, we have been provided a Transform the Practice grant, which is covering most of these costs right now as we get our clinical infrastructure in place. So what happens in the context of cancer? So how is CHIP relevant in other cancers? So there's a very elegant study by Memorial Sloan. They have a very well-established program called the MSKCC Impact, where all cancers they've studied, they've shown the prevalence of CHIP in. And of course, there's age dependence. So as you can see here at the top of the plot on the left, some of these cancers that arise later in life, in the 7th or so decade of life, there's up to 50% CHIP prevalence. But even at the bottom, these germ cell tumors that arise in the 2nd or 3rd decade of life, there's still 12% prevalence of CHIP. So if you have CH, not just CHIP, any mutations, even without involving a leukemia driver, they show you have a higher risk of therapy-related myeloid neoplasms. But if this involves a driver mutation, then the risk goes up very high. So they're able to show that this is relevant in other cancers. While we initially thought a lot of these genes are only associated with MDS and leukemia, and this is clearly a myeloid-specific state, however, this paper in Nature Medicine clearly illustrates very eloquently that there is a specific signature of genes, especially lysine methyltransferases, ATM, and part of the DNA damage response that are associated with lymphoproliferative processes, especially chronic lymphocytic leukemia and non-Hodgkin's lymphoma. And then this just underscores the need for understanding consequences of myeloid versus lymphoid CHIP signatures. Now, in bone marrow failure syndrome, CHIP influences the fitness. And this has dual implications. So these are clonal processes, and they carry mutations in the epigenetic regulators and transcription factors, which I've shown before, and these are moving towards a myeloid neoplasm. Whereas if they have mutations, secondary mutations in PIG-A, BCOR like 1, they respond well because they have a loss of survival advantage. Our current hypothesis, we think that CHIP is a rescue phenomenon in bone marrow failure syndromes because the stem cells are primed for premature death. CHIP occurs, providing clonal fitness, providing a clonal stemness, and allows some degree of recovery. But of course, this is an imperfect system which is why the risk of malignant evolution. So we're very proud to be able to have clinical trials, which we've been able to have in the clonal cytopenia space. We're excited about high-dose IV ascorbic acid, vitamin C, which has been shown to modulate TET activity. And right now we're targeting TET2 mutated patients. We have other trials at outside institutions, including an IDH1, IDH2 inhibitor study, anakinumab, and also we're targeting the inflammasome with the NLRP3 inhibitor. So ladies and gentlemen, in summary, clonal hematopoiesis of indeterminate potential is very important. It's defined by expanded somatic mutant clones in the stem and progenitor cells. It increases risk for hematologic malignancies and is also associated with all-cause mortality and cerebrovascular and cardiovascular outcomes. But most important, genomic clonal structure is unique and relevant in every individual. And aside from all the high-optic sequencing panels we do, integrating this into patient care using multidisciplinary teams and functional applications is and will be essential to the best and most informed care for patients. So our aspirations and next steps. Right now, we're currently working with the Mayo Clinic Advanced Diagnostic Laboratories for clinical development of a single index large gene target capture error-corrected sequencing panel, and also a dual index 25 gene more focused error-corrected sequencing panel targeting the most representative clonal hematopoiesis genes. We'd like to use this for minimal residual disease monitoring. Secondly, and very importantly, we would like to have more accessibility to minority populations. When we do risk-benefit ratios for minority populations, this is on databases that are biased towards, Midwestern Caucasian populations. This is not necessarily something that's, we should be doing, and so there's a critical need to assess this. And also, number 3, expand our clinic to other oncology practices enterprise-wide. We would like to do this. And we're moving towards it right now. We're actually having some success, especially evaluation of post-chemotherapy cytopenias, pre-chemotherapy counseling to assess risk for therapy-related neoplasms, and assess implications beyond heme malignancies. So I'd like to end with a case. This is a 35-year-old female. She was diagnosed to have stage 2 infiltrating ductal adenocarcinoma of her left breast. She's hormone receptor positive, HER2 negative. Her mother had polycythemia vera, and she had a maternal grandmother with multiple myeloma. So they sent her blood for hereditary breast cancer genetic screening for some of the most relevant genes, and it came back. She was found to have a TP53 mutation in 14% of her leukocytes. So this is unlikely to represent mosaicism and likely to be clonal hematopoiesis. She didn't have any abnormal blood count. Her CBC was completely normal. Now, she's only 35 years old, and you're about to discuss adjuvant chemotherapy with her. What we know from heme malignancies is if you have a P53 clone, you throw chemotherapy on it, the more this clone is going to expand, the more this clone is going to select out. And this is a primary reason that these patients get aggressive therapy-related myeloid neoplasms. So annually, the world adds 6,000 to 7,000 cases of MDS and AML in young women for only a 3 to 6% reduction in relapse rates or survival benefits. And this is more pronounced in specific therapy types. So there is a very strong need and role in screening these cases for CHIP. Whereas we might not be able to do anything right at this moment for the patient once we have this information, every patient needs to be educated and empowered with this information so that they can have the knowledge and be able to understand their risk-benefit ratio and make their own decision. So we've seen a number of cases come in after they've actually gotten a therapy-related myeloid neoplasm, and these patients didn't even have a good idea that this would happen to them 2 years after chemo radiation therapy after their cancer. And this is really sad and unfortunate. So finally, I want to do some acknowledgements. Now, there is nowhere near the amount of names on this slide that need to be. We're very fortunate and blessed at the Mayo Clinic to have support from the Center for Individualized Medicine, and the Division of Hematology was led by Dr. Lacey. We received a Transform the Practice grant, and we're now enterprise-wide, all 3 Mayo Clinic sites. We have a clinicaltrials.gov site you can go to and refer your patients. To date, we've accrued over 250 patients. These patients have provided samples, so we have an active biobank. We're working with patient foundations, rare germline disease groups, short telomere syndrome disease groups, and so this is very robust. It's a work in progress. It's a journey that we've all been on. I'd like to highlight my team, Dr. Myrnal Patnick, who is the inspiration behind this whole clinic, and the rest of the clinicians, laboratorians, and our clinical support team, leadership from Center for Individualized Medicine, and our Mayo Genomics Core, which is the workhorse behind all of our sequencing needs here. And thank you very much for allowing me to present.
Thank you so much, Dr. Lasho, for the wonderful, wonderful talk. And we do have some time for questions, so please feel free to come to the microphone, yes. And meanwhile, we can start with the first question from the virtual attendee. How often are the VUS turned into the clinical actionable variants, and how are these variants further characterized?
So that's a very good question. We see a lot of VUSs. We have several teams, bioinformatic teams. We use a lot of knowledge-based databases to annotate these. As much as we can, we have outreach to different areas where we can functionally analyze these variants. But for the most part, right now, I think we're characterizing these, we're annotating them in databases, and I can't really say for sure. I mean, it's the critical need that we all have, right? I think the difference with our team is, these are actionable right now if we have the ability to functionally annotate them, because we have the patient right there. This isn't like a database that we're curating, and so this puts more of a need on us being able to define these variants. But it's a very good question, and it's something that needs further annotation, and hopefully we're working towards that.
And maybe take the question from the audience.
Hi, great talk. So, are you informing the patient, like that breast cancer case? I mean, I think that's a great point, right? Because the adjuvant chemotherapy you have to wait, right? So this is already clear in the literature that if they have a mutation in a DNA repair gene, they have a very high chance of developing an MDS or AML. But I've never seen that being brought to the clinics. So my question is if you are already bringing this information for the patient to decide if they are willing or not to proceed with adjuvant chemotherapy?
That's a great question. So we do provide consulting to the patient care teams, and we're having more of a hands-off approach now as we integrate this, but we are making the patient aware. If they're referred to our clinic, absolutely. If they're directly under the care of one of our hematologists in our CHIP clinic, then absolutely, they're having control over when they get chemotherapy, and they're providing their expertise on that. But this is something where we hope that in the future, everybody that's going to be receiving these types of therapy can have access to this type of testing. And only because we're implementing this now. I mean, this is actually us on the ground running with patients. It's not a pipe dream. It's not a database. It's not a consortium retrospectively of some data somewhere. This is actually patients that we're dealing with. And we want to make them not a mortality. We want to make them be able to be as well informed as they can be. Because, I mean, patients now are walking into physician offices and they have their full genome in their hand right there. And so, we all know how difficult it is to be able to match this to an actual program, but we hope that by what we're doing here, it's a functional, and it's yeah, like you say, we would like to be able to have this be a critical point in deciding whether or not these patients have this kind of therapy.
Good, congratulations.
Oh, thank you. I want to go back to the VUS interpretation. So you mentioned that you have a team of people. Is this an automatic, this is a VUS, it gets shuttled off for interpretation?
Absolutely not.
No,
So there is a lot of manual annotation. There is a lot of collaboration with different groups. This is a work in progress. This is a journey. And attending, conferences like this and being able to network and help, which is helping us to establish this infrastructure. Right now we can pick the low-hanging fruit with these cytopenias and what direction we want their treatments to go. But while we're doing this and we're accumulating this information on VUSs, and we have the Transform the Practice, grants and money available to be able to pursue some of these, variant annotations functionally, it's yeah, like you say, it's tough, but we're in the process. It's a journey.
Given that they're coming up on so many sequencing panels now that are being run in the routine clinical setting, perhaps we should link you up with the ClinGen project, and that listed some of the FLT3, the others that maybe we should put DTA in as, DNMT3A as a project group of genes that could establish a working group for functional annotation of those.
That would be amazing.
I think
there's also rare syndromes that we've come across, like Tatton-Brown-Raman syndrome, which is a germline DNMT3 syndrome. We've reached out to the Patient Foundation for that, and they have very well annotated these different mutations in that rare syndrome. And so things like this we're actually becoming aware of now because of the exposure of our clinic. And yes, as you say, we would love to be part of whatever we can to be able to get this more momentum and be able to prove proof of principle, bench to bedside, and hopefully we can have this everywhere implemented someday.
Thank you very much.
Hi, my name is Taylor Walker. I'm actually a coordinator in ClinGen for the myeloid malignancy variant curation panel, so this is like perfect
Cool.
timing with these questions. I really thought your talk was interesting from the variant curation side. A lot of times when we do have VUSs, one thing that my panel tries to do is find that patient data so we can kind of push it into some kind of categorization. But one of the problems that we come across is sometimes when variants are deposited, it'll have like a note that there's a patient with this variant, but since it's not necessarily attached to like published data, we're not able to kind of use it and reference it because we have to have something to go back to verify it with. So I guess my question is, are you guys looking to be able to publish this data in some way or like connect with panels, kind of share it with them? I know there's an issue around trying to protect that patient privacy, so that's important, but we also are so interested in getting that patient data so we can kind of use it in our curations.
Yeah, no, we're open for collaboration. So a lot of these variants of undetermined significance are in genes we know a lot about. So we know a lot about the domains, the functional aspects of the genes. And so we're able to make educated decisions on functional analysis and validation of these VUSs. And so I feel like we're in a pretty good spot with a lot of this stuff. But then that being said, we're also past it. So we're recording these VUSs as these patients come in to see if we have any correlations, between what we're seeing and the patients that are coming in and their phenotypes. And yes, we're actively open for any collaboration or any, help in building our infrastructure, especially with variant curation, which I feel like that's part that's, that needs to catch up and, moving forward needs to be a lot of focus on.
Awesome, very cool talk. I'll send you an email. Thanks.
Hi, wonderful talk. Maybe you said this and I missed it, but what is the lower limit of detection for VAF for your assay? And then what are you considering like clinically significant? The case that you had presented with the woman with breast cancer who had the T53 variant, 14% seems pretty high, but what if it had been at like or lower?
Yeah, that's a great question. So the first part of your question, our target capture panel has a reliable detection rate of 0.5%. And this is relevant because some patients that come in with low blood counts, they had a clinical panel done, but some of their lower threshold of detections are only 5%. And so when we use our assay, we actually pick up a lot of things that the clinical panels miss. And so when we do CLIA validation, we have to go to somewhere that has this low sensitivity detection. And there's not a lot of, places that, it's outside of the Mayo Clinic, and we don't have one in now. We're getting one in now. But yeah, so it's 0.5%. And then the other part of your question, so the patient that I talked to about with the 14% TP53 mutation, so this is TP53. So even if it was 0.3%, if you throw chemotherapy on that, it would be relevant, like it would expand. And so this, exacerbates our need for a very high-depth sequencing error correction platform in order to be able to interrogate this. So yes, absolutely, we need to detect everything, especially when it's sensitive to radiation or chemotherapy like this. We were fortunate to be able to detect this before this woman was given chemotherapy so that we could, help her make her own decision. But yeah, I mean, if the lower the sensitivity, the better.
Thank you.
I just have a question about over time, what happens with these clones? Do you have any data on that? We know that in some cases of clonal hematopoiesis, some of the clones are actually transient and that can come and go. And I'm just wondering about if you have any data on any of these variants. Does the clones always expand, or do they evolve over time, or do you ever see anything that is like a transient clone?
That's an excellent question. So a lot of these clones are very stable, we've noticed. And there was a recent report that was just released on multiple myeloma with lenalidomide use. I don't know if anybody's aware of it, but it seemed in this study that the presence of CH was actually protective in these cases, and the patients did better if they had CH under lenalidomide treatment. So I think there's a lot of dynamics that we don't necessarily understand right now, but thankfully we're able to, as these patients come in, we're able to, record this, and, kudos to the patients. I should have put them on my acknowledgement slide, but a lot of them give their lifeblood every time they come in, and so we're able to build a biobank. And so we have samples, we have the clinical histories for all of these cases, and so we're able to follow them as they proceed through their journey. But for the most part, I mean, a lot of these clones are very stable.
So one last question from Q&A. Has any studies have been done in supercentenarians to elucidate that the VUS may not have any impact?
Not that I'm aware of with our group. I know there's studies out there that have looked in it.
Awesome. And there's actually a comment from the virtual attendees. It's not a question per se, but I would like to share the nice comment with you. Your talk is excellent.
Oh, thank you.
And would you mind to share your slides for teaching purpose and maybe the email address for further questions?
Yes, absolutely. I mean, it was nice to be able to share like a story of hitting the ground running. There's so much effort that's been placed on variant annotation and how far we've come, and look at all these beautiful guidelines that we have. But to be able to execute it and share that, some of our success stories, some of these patients that we've been able to help, I know on one of the slides I didn't mention, but we saw 120 cases, and 65% of these we were able to have actionable things that were able to help these patients care in their therapy. And so, it's inspirational and heartwarming, and yes, I was glad and very happy to share. So thank you.
Was that?